I now request Dr. Greg Stone and Dr. Ajay. Ajay and Dr. Stone, sir, you can take over and conduct this session. Over to you, sir. Thank you, sir. Over to you.
Of course. Well, thank you for having us. This is something that I really enjoy doing every single year with Ajay and Ashok and all the other directors and co-directors. And again, hopefully we'll be able to meet next year in person, but at least for now, this is a great way to do this. So thank you again for having us. So we have a great session over the next hour on the stent decisions that we make every single day. What's more fundamental than choosing the optimal stent for the optimal type of patient, and to really look at the data and clinical experience to see the extent to which this really makes a difference to the outcomes for our patients. So why don't we go directly into it? And our first talk is going to be by Ajay, and he's going to talk about the major differences between durable polymer and bioabsorbable polymer drug-eluting stents, evidence and experience.
All right, thanks so
much. Dr. Dangas, and Ajay will be talking on the tailoring antiplatelet therapy in our patients, what is old and what is new.
Yeah, there was a slight change in the agenda, and then
I'm sorry, I didn't know
George. That. No, that's okay. It'll be a great session though, irrespective. And honestly, from our side, you know, it is, as I'd echo Greg's statements, it's too bad that we can't be there. It's amazing that you're able to pull this off in multiple cinemas throughout India, and we just you know, long for the time when we can all be together again. We have to keep deferring it over and over again, but I think it'll come at some point soon. So I'm going to talk briefly about tailoring antiplatelet therapy to our patients specifically. I'll talk a little bit about history and then what's new out there with some data updates in that regard. Here are my conflicts, none's particularly germane to this topic. So I think it's important to talk, when we talk about antiplatelet therapy and what we're trying to do with it, to speak specifically about stent thrombosis, because for those that are junior and weren't around in these times, it's remarkable that the initial rates of stent thrombosis were almost 20% in the early history of stents. It was only after first Coumadin, then Dextran, and all kinds of anticoagulants that it could be reduced to under 5% levels. But until Antonio Colombo and others sort of identified the fact that you could inflate these stents at high pressure and institute DAP, that then the rates of stent thrombosis became under 1%, which allowed stents to become ascendant as the primary way we would treat coronary artery disease in the cath lab. So that's an important evolution over time. These are just some of the data showing how it got to that point, because again, if you're above 1%, more than 1 in 100 patients having a stent thrombosis, it's going to be very hard for that therapy to be the default. And so it was with studies like this that looked first with aspirin plus ticlopidine that demonstrated reductions in stent thrombosis that stents could then move forward. Now, fast forward several decades, and what you actually saw is that perhaps if we continued dual antiplatelet therapy for longer periods of time, because with drug-eluting stents, we knew there was a risk of late stent thrombosis, could we further reduce adverse events? And that was the primary hypothesis of the DAP trial. And while that study did show that you could reduce ischemic events by continuing dual antiplatelet therapy beyond 12 months, the study also showed that you increased rates of bleeding. And so ischemic events were down, bleeding events were up, and the net of that actually within that study was to show an increased mortality with extended duration dual antiplatelet therapy. That really is emphasized in this slide, which shows that there's no free lunch. There's a risk associated with stent thrombosis, which causes you to try to increase your antithrombotic therapy, but that also incurs a risk of increased bleeding. And so there's a balance here. And in an individual patient, we can't choose a one-size-fits-all approach. We need to titrate the balance of the ischemic risk versus the bleeding risk, and then come up with the best prescription for the patient. And that allows us to maximize their outcomes. And this is just a slide from the DAP study that showed that there was this increased risk of bleeding associated with extended duration DAP. Now, Greg and others have been very involved in the work with looking at bleeding outcomes. George, Roxana, our group. And this was in a paper published in JACC in 2015 that looked at if you had a bleeding event post-discharge, that was associated with a greater incidence of 2-year mortality than if you had a post-discharge myocardial infarction event. And that's one of the reasons why, as cardiologists, we tend to fixate on preventing myocardial infarctions. But as physicians, not just cardiologists, we need to fix on the whole picture, and that's both a combination of bleeding events and ischemic events. This was just an analysis we published from the ADAPT DES registry, where we actually looked at the specific agent itself and its potency, and the response of the individual patient to that agent. And what we basically showed is that if you reduce the antiplatelet effect, in other words, if you reduce platelet activation to the point where platelets are very inhibited, that's great for preventing stent thrombosis, but it also increases bleeding. On the other hand, if you don't really respond on the right of this slide to the antiplatelet agent clopidogrel, then your bleeding rate is lower, but of course you're at higher risk for ischemic events. So it's not just the duration of effect, it's the potency of the drug, it's the patient responsiveness, and all of this needs to be taken into account. There's been a lot of interest of late in terms of looking at high bleeding risk with scores out there assessing what this bleeding risk would be. And there are many clinical characteristics and presentation findings that would actually cause what we call predictably high bleeding risk. But then there's also unpredictable bleeding risk. So in some patients, they may be at low risk for bleeding, but then they undergo a car accident and they automatically become at high risk for bleeding. And so there are other things that contribute to that. And I like to show this picture as an example of that. This is a patient of mine, this was with permission, who is very strong. He's an elderly gentleman, has enormous biceps, but he also has this spontaneous bruising, not only in his arm, but also in his face. And this is just from the dual antiplatelet therapy that he's on. So by all clinical characteristics, he might be low risk based upon certain things. But then if you look at him, he's actually higher bleeding risk. And so we need to titrate our therapies to this patient. So let's get to the data. How do we make some of these decisions? Should DAP be titrated based upon clinical presentation? Well, first, if we look at acute coronary syndromes versus stable disease, that our guidelines do say there's a difference. And if you have acute coronary syndromes, typically you're going to treat for longer. And if it's stable, you could treat for shorter. And that's true both for normal bleeding risk as well as high bleeding risk patients. This is based upon data from studies like the DAP trial, which looked at the absolute risk reduction in patients with myocardial infarction, which was greater with extended duration DAP than it was for non-acute coronary syndrome patients. In addition, trials like the Pegasus trial, which continued ticagrelor after an MI event and randomized the ticagrelor versus placebo, showed a benefit in terms of reduction in ischemic events for these patients with prior myocardial infarction. So it does appear that patients with systemic inflammation, if you will, systemic plaque vulnerability, are going to benefit from longer duration dual antiplatelet therapy. And there is this one intriguing study, the SMART DATE trial, which looked at discontinuation early in patients with acute coronary syndromes. And there does appear to be a hazard of increased myocardial infarction with this early discontinuation, if you will, versus continuance for 12 months. So I think these MI patients are probably a little bit different. In terms of the type of agent we use, these patients are probably also different because it's one area in the ACC/AHA guidelines where a specific drug is recommended over another specific drug. Unlike the European guidelines, which do that all the time, in the US, we're very loath to do that. And in this particular circumstance, more potent antiplatelet therapy, either with ticagrelor or prasugrel, is preferred to clopidogrel in patients that have acute coronary syndromes, particularly non-ST segment ACS. Finally, I'll point out to this paper here, which basically was a meta-analysis looking at guided versus standard dual antiplatelet therapy. And it did appear that through either escalation or de-escalation based upon guiding the therapy on responsiveness could be associated with increased outcomes. I think there's a lot of controversy in this area because no individual study has shown it, but in amalgamation together, there is this signal that suggests that guidance might be beneficial with the caveats of a meta-analysis, including observational and randomized trials. What about anatomic complexity? Well, it turns out that as you get more complex in terms of your lesion characteristics as defined on the left of the slide, there is a greater incidence of ischemic events, and there is some data suggesting that longer duration dual antiplatelet therapy might be beneficial in that patient population. But what's interesting is that if you're at high bleeding risk, then that complexity does not supersede the higher bleeding risk. And if you're at higher bleeding risk, those patients across the board, whether they're complex or not complex, at least in this study, did not benefit from longer duration of DAP. And so it's important that we as interventionalists often fixate on the lesion, but we need to fixate on both the lesion and the patient. And if the patient's bleeding risk is high, that might supersede what we talk about. This was nicely put together in the editorial to that analysis that I showed earlier, where essentially there are a variety of characteristics that go into the decision making and can guide switching, can guide de-escalation or escalation. I'm not going to go through this in detail. I just show you this slide so that if you want to read the article and read the way it's synthesized, it makes a lot of clinical sense, and it's one of the most updated things that you would potentially read. Now, briefly moving on to minimum duration of DAPT after a coronary stent, and I'm not going to go this in detail because I know Greg is going to cover some of it. I'll point out that this question is, while the studies have been generated and done in patients at high bleeding risk, these data are relevant for all patients because you never know who's going to become high bleeding risk, who's going to have a surgery or otherwise that you might need to discontinue your dual antiplatelet therapy. In addition, because the studies are done in high bleeding risk patients, most of those data can likely be extrapolated to lower bleeding risk patients as well because they tend to be lower risk as a whole. So there are a variety of ways that you can modify stents and do things to them to make them safer and to reduce their thrombotic risk. And I'm just going to go through some of the data with various stents quickly. If Greg covers it as well, I'm sure he'll do it in more detail. This was the first data sort of looking at a drug-coated stent in liters free that basically showed that you could, with a reduced duration of dual antiplatelet therapy, get better than the results with the comparator bare metal stent. That's the same stent platform as the BioFreedom. And what's important to note is that these things are not commoditized. It's not that they're all it's one size fits all. All of these different stents have different strut thicknesses, they have different polymer types, they have different polymer distributions, elution characteristics. And so my view on this is that in general, you would like to see data with specific stent types demonstrating safety of shorter durations of DAPT. That's one of the things we tried to do in the Evolve Short DAPT study. This was a registry looking at patients treated with 3 months of dual antiplatelet therapy and then discontinuation to aspirin alone implanted with the Synergy stent. And what we were able to demonstrate is that in these patients that were event-free out to 3 months, there was a very low risk of adverse events, especially stent thrombosis, in the subsequent follow-up period. And this data was published in Circ Interventions. In the Onyx 1 trial, which Greg and I have both been part of, what we aim to do is actually randomly compare 1 month of DAPT with the Onyx zosterolmus-eluting stent compared to the BioFreedom stent, also with 1 month of DAPT. And by randomizing, it's a true apples-to-apples comparison as compared to some of the other registry studies where it's a comparison to a historical control. What we were able to demonstrate is there were really no differences in the primary endpoint of cardiac death or myocardial infarction or stent thrombosis seen with this approach, therefore establishing that a 1 month duration of DAPT could be sufficient with this Onyx ZES in high bleeding risk patients, and actually high bleeding risk patients who were somewhat unselected. So this included STEMIs, it included complex PCI lesions, which also differentiates it from some of the other studies that have been out there. We further went and looked at patients in that study enrolled in Europe, combined them with patients enrolled in the US and Japan, and showed that the results of stent thrombosis in particular, but also cardiac death and MI, were quite acceptable based upon the assumptions that we had made previously. You know that there's new data with the Xience stent, similar sort of design as Evolve Short DAPT, where we looked at patients, where patients were looked at 28 days and 90 days of dual antiplatelet therapy and then discontinuation. Once again, very low rates of stent thrombosis. This is the 90-day data. This is the 28 data, and also similar to a comparison with the Xience v USA data as a whole. So with that, I think we have established that shorter durations of dual antiplatelet therapy in high bleeding risk patients can, for the most part, be done safely. It's not proven per se, because we don't have the sample sizes to justify it, but overall it looks pretty good. But are there other options besides shortening the duration of DAPT? And is there a way to perhaps de-escalate therapy? And one of the ones that we've seen a lot of data most recently is monotherapy. So this is one of the first trials that came out with regards to that, Stop DAPT 2, done in Japan. Very high rate of imaging-based guidance. So I want to throw that caveat out there because that's important for clinicians to understand, especially if you're using clopidogrel, where you know there's some degree of non-responsiveness. This data is hard to extrapolate unless you're using a lot of imaging, but essentially a course of 1 month DAPT appeared to be more beneficial, specifically reducing bleeding risk compared to 12 months of DAPT. And that's what these studies will all show, is that if you de-escalate, you're generally going to reduce bleeding. And the question is, do you incur a greater ischemic risk in doing a strategy like that? This was Smart Choice, similar study presented, I think at the same time as Stop DAPT 2, showing that you could reduce bleeding events by just going to P2Y12 inhibitor monotherapy as opposed to aspirin plus the P2Y12 inhibitor. We all know the Twilight study that Roxana Moran led, which was basically a study where aspirin plus ticagrelor was given for 3 months, and then the aspirin was dropped. And in this study, there was a clear reduction in bleeding associated with that strategy without a penalty in terms of ischemic events over the long term. Now, I do think that ticagrelor or prasugrel, for that matter, are probably safer ways to discontinue your aspirin because, as I mentioned before, there's a certain rate of non-responsiveness to clopidogrel. And if you drop aspirin and continue clopidogrel, but the patient's a non-responder, which I know you all see in the South Asian population, then the patient's really on no antiplatelet agent, and that's something that would give me a little bit of concern. There are some studies that have done that, though, at longer periods of time and haven't shown deleterious events. Finally, in the STEMI population from TCO-STEMI, same sort of findings as Twilight, reductions in major bleeding without an increase in ischemic events. 2 other final studies I'll show before I wrap up that were presented at ACC, which are, I think, pretty important, are this first one, which was host exam from Korea, where patients who were event-free under DAPT after PCI were then randomized to aspirin or clopidogrel, just one of those agents. And this is something that comes up in the office all the time. In this analysis, there was a reduction in events, thrombotic events, and actually, interestingly, in bleeding events seen with clopidogrel monotherapy versus aspirin monotherapy. I will say, even before this study, this was something I've kind of adopted in my practice for patients that are on dual antiplatelet therapy. I do often drop the aspirin over time, and it was nice to see this data somewhat corroborating that. Finally, the last study I'll show is Talos AMI, which was a trial where patients were treated with aspirin and ticagrelor for 30 days, and then essentially de-escalated to aspirin plus clopidogrel versus aspirin plus ticagrelor. And at least in this study, there did not appear to be a harm to de-escalation to clopidogrel. There was certainly a reduction in bleeding that was seen in the study as well. So I gave you a ton of data, a ton of data points out there, but let's bring it back to the patient. And how do we think about titrating DAPT to our patients? I think first, it's important to state that current generation DES are very safe. And recent studies have demonstrated that shorter DAPT durations, especially with the stent types that have been studied, are also safe. And so that's a good thing because it gives us options. But it certainly doesn't mean that it's shorter DAPT for every patient. We need to think about the patient individually, just the clinical scenario, the angiogram itself, and understand that there's specific populations that might benefit from longer or more intensive DAPT duration and potency. And so ACS is one group. I think I showed you examples of that. And then complex PCI is another, although it doesn't necessarily supersede high bleeding risk. Finally, the stent protective effect aspect of DAPT is always a priority. But remember, it's not just about the stent, it's about the overall patient as well. And so this is going to be a moving target over time. That's one of the reasons why we like to continue DAPT, particularly for our higher risk patients. And in that regard, the thing we really want to do is lower bleeding risk. And the way we can do that is by going to monotherapy and de-escalation in that way, which ultimately may be the sweet spot for our patients. Thanks so much for listening, and happy to take any questions at the end of the session.
Thank you, Ajay, for an excellent talk. And what we have been doing was also same. Whenever patients were intolerant, we were stopping aspirin and giving clopidogrel. And probably in future, clopidogrel could take the place of aspirin. And one other point which you highlighted very well is whenever you're moving from DAPT to single antiplatelet, it's not the aspirin which is safer to continue immediately, but the ticagrelor or prasugrel. That's what you have mentioned. Though in some resolute onyx, some of them were also put on only aspirin after 1 month. I think in clinical practice is important to follow, especially as you said, in Indian scenario, we do see little more thrombosis. I think it is very important.